Thank you and good morning, everyone. And on our News Extra today, we have Dr. Rommie Hughes, who's the General and Vascular Surgeon with Regional West Physicians Clinic. Thank you very much for joining us today.
Thank you, Scott.
And we're talking about a medical condition that does impact a fair number of people, and it's abdominal aortic aneurysms. Had to make sure I said that correctly.
Yeah, that's correct.
A condition that actually, come to find out, can run in families.
It can. Yeah, aneurysmal disease is just a dilatation of any of the vessels in the body. And what we're talking about today is a dilatation of the abdominal aorta. Mm-hmm. And if people have had anatomy or remember anatomy from high school, the aorta is the main blood vessel in the body that delivers blood to the whole entire system.
Extremely important, of course.
Yeah. And if that dilates, and as it dilates over time, most people don't know it's even happening until it's too late. And then when it ruptures, it's basically just a hole gets blown in the aorta, so you bleed out of that hole. And so if it were to rupture before it's identified and treated, the mortality is exceedingly high. Mm-hmm. Even with operative intervention, the mortality is 80% or so.
Wow. Now, these types of events generally don't present themselves before they necessarily happen. And my understanding is that usually when somebody comes across having an aneurysm, whether it's aortic or even otherwise, it's usually because we're looking for something else.
You're exactly right. And aneurysmal disease, and particularly abdominal aortic aneurysms, have been known as the silent killer, because unless you get imaging for some other reason, somebody has abdominal pain or they may have back pain or something else, and they get an ultrasound or a CAT scan or even a plain radiograph, that's when they usually identify those aneurysms, and that's why screening becomes so important. Okay,
and speaking of screening, there are tests out there that can help identify the potential for these instances to happen in individuals.
There are, and you look at the categories of the people that would most likely get an aneurysm, and you look at family histories, number one, mother, father, brother, sister. If they've had an aneurysm anywhere in their body, actually, they need to be screened. If they have a history of smoking, if they have a history of high blood pressure, or any other vascular risk factors. And the best screening modality is actually ultrasound. Okay. And with a little ultrasound probe, it's totally painless. Within less than 2 minutes, you can tell if somebody has an abdominal aortic aneurysm.
And, well, high blood pressure being one of those indicators for somebody that needs to be screened, but that's a lot of people.
It is. But the screening is so simple and so quick that everybody should be screened if they have those vascular risk factors. You know, in America, our habits may not be as good as they should be. And everybody doesn't eat what they should. High instance of obesity.
Not as much exercise, yeah.
Exactly, and we're all guilty of that.
Sure.
And so there's a huge number of people that need to be screened. And one of the good things now is with the entry to Medicare examination, it actually includes a screening for abdominal aortic aneurysms.
Which is excellent because a ruptured aortic aneurysm, the 10th leading cause of death for men over 55.
It is.
And so it's especially important as you age to start considering these types of things that could be a potentiality in your health history going forward.
It is. And as we as a nation become more health conscious in the way we eat and exercise and starting to be aware of these things, we can't forget about our vascular system, and we need to have not only the aorta but your carotids and other screenings done for just vascular disease in general, because everything's treatable, at least modifiable to lessen your risk of dying from these things.
And of course, once something has been discovered with the potential to have an aneurysm, there are surgeries and procedures that are available to take corrective steps. And we'll be back in just a moment to talk with Dr. Hughes about those here on News Extra. And we're back on News Extra, and my guest today is Dr. Rommie Hughes, the General and Vascular Surgeon with Regional West Physicians Clinic. Again, thank you very much for joining us today.
You bet. Thanks for having us.
We're talking about abdominal aortic aneurysms, something that can affect men and women, but it's actually quite prevalent, the 10th leading cause of death for men over the age of 55 when there's a rupture that happens. Doc, these are instances where you can be screened for these. Now, what happens as far as treatment once somebody is discovered with this type of a situation?
Sure. If somebody has an aneurysm, and aneurysms will grow at certain rates, different in different people. And not everybody that has an aneurysm needs treatment up front.
Sure.
And so what we look at is the size of aneurysm. If you have historical data, the rate of growth of that aneurysm, and we try to predict what the rupture rate is based on the patient's age and based on the size of the aneurysm.
Sure.
Some people just need to be followed annually or every 6 months, and then we intervene when the risk of the aneurysm rupture is greater than the risk of the operative intervention.
Okay. And of course, the operative intervention, it sounds like these procedures are actually relatively, no procedure is simple, mind you, but they're relatively non-invasive. It certainly seems like.
It really is. Aneurysm surgery's come a long, long way. In the old days, you would have an incision from just below your breastbone all the way down to your pelvis. You'd go in and you'd replace the aorta with some type of artificial material, hand sewn, and those people would be in the intensive care unit 4 or 5 days, hospital up to 10 days, and never back to their preoperative state of health or activity level, probably 6 weeks. And there were a lot of other complications that could happen in that time frame. Now we do it all minimally invasive. So we work through the legs, either make a puncture mark or just a small incision in the groin, and we work inside of the blood vessel, and we deploy something called a stent graft, which is basically a wire cage with fabric sewn around that.
Okay.
And we deploy that above the aneurysm and below the aneurysm, and the blood flow goes through that graft, eliminates the pressure in the aneurysm,
Sure.
lessens your chance of rupture.
Now, once these are done, what are the odds of success, reoccurrence, things such as that? What are we looking at as far as an outcome?
The outcomes are very, very good. And all aneurysms are different. And we like to say everybody's a bit of a snowflake anatomically. But the success rate is as high as 98 to 99%. Most of the treatment goes into the planning of these operations.
Sure.
They get special CAT scans where we make measurements. Sometimes we do 3D models, and then they actually form the grafts based on the patient's anatomy. And then they go to the operating room. The deployment rate's 99%. Now, after we put them in, they're committed to lifelong surveillance
Sure.
afterwards.
Yeah,
and
you'd
so
have to be.
the aneurysm and their morphology and anatomy will change over time. So we follow them yearly to make sure everything looks like it should. There is a reintervention rate of about 8 to 10%, but most of the times that can also be done with catheter-based technology without having to go to the operating room. If you have one of these aneurysms treated with an endograft, minimally invasive, the chance of your aneurysm rupturing in your lifetime is less than 1%.
Wow, that's amazing. That's amazing,
is.
and it's really kind of surprising that it's not a one size fits all graft that takes place. It's actually tailored to the individual, it sounds like.
It is. And it's kind of like building blocks with inside of the aorta. And so we have different components that we can match and different things we can do to tailor that to their anatomy.
Wow, that's really amazing. Now, of course, one of the most important steps for anyone to kind of circle back to it is knowing that you have this potentiality that you might have an aneurysm that's present. So let's talk about screening, because that is the really key to getting ahead of these things.
It is. Anybody who has a family history of aneurysmal disease or any vascular disease, whether they've had strokes, they have heart disease, they have a peripheral vascular disease, they need some sort of screen. For the aneurysms in particular, it's an ultrasound, and it should be, if you've had a family member with an aneurysm, over the age of 50. If you're Medicare age, if you have hypertension, had any history of tobacco exposure, you need a screening. Sometimes that screen is just a one-time deal.
Sure.
If you get your screen and you have no aneurysmal disease, then you don't need another screening. If you have a small aneurysm, then it's surveillance after that.
Okay.
Screening's totally painless, takes less than 5 minutes, and there's no radiation exposure.
And this is something that can be done at Regional West Physicians Clinic through the hospital. It's some aneurysm screenings available here.
We do. Either through their primary care physician, they get a referral, they call our office, and we do screen. We have dedicated vascular techs in our office that's basically all they do.
Yeah, and so to schedule something such as this, if you feel you need it, or if your doctor says you need it, you can call the Vascular Diagnostics. That number is 308-632-2872. Aortic aortic aneurysm screening, health, and prevention, very important for people, especially in our area. We do have an elderly population that has grown.
No question.
Doctor, thank you very much for joining us today on News Extra.
You bet. Thanks for having us, Scott.